Welcome to this PCR webinar series dedicated to myocardial ischemia without obstructive coronary artery disease. This is the last module of this series of webinar, and it is dedicated to INOCA in a specific clinical scenario. My name is Emanuele Barbato from the Cardiovascular Center Aalst in Belgium and from the University Federico II in Italy. And I have the pleasure today to share this webinar with other two renowned international faculty, Marta Gulati from the University of Arizona in the United States and Javier Escanet from the Hospital Clínico San Carlos in Madrid, Spain. Our objective today are to revisit the causes of myocardial ischemia without obstructive disease. We will try to understand with you that INOCA frequently happens in patients with concomitant epicardial stenosis, and we aim at learning how to perform and interpret intracoronary tests in these patients. But let me take you directly into the core of this webinar, and let me share with you what are we talking about. We are talking about patients like the one in this case example, a 54-year-old female patient presenting with typical angina irrespective of the exercise activity. Exercise ECG was non-conclusive for reversible ischemia, while CCTA demonstrated an intermediate stenosis in the proximal left anterior descending artery. On the left, you see the coronary angiogram performed in these patients that actually showed a tight stenosis of the proximal LAD. Invasive functional evaluation with FFR showed a lesion with a value of 0.58. After this clinical background and knowing that invasive assessment in this strategy in this patient has been done, let me ask you what would be your strategy in this case. Who among you would rather go on, close the story, and stent the proximal LAD? Please choose option 1 in the chat box. Who would rather perform intravascular imaging first, possibly followed by percutaneous coronary intervention, depending on the option, on the result of the imaging? Option 2, who would send this patient to surgeons? After all, it's a proximal LAD stenosis. And finally, who would go for optimal medical therapy in this case? So while you are taking your time to answer this question, let me ask my colleagues, what would they do in their practice? And let's kick off with Marta. Marta, you have this patient in your practice. How would you react to this story, to the information received?
Well, you start with the non-invasive cardiologist, right? So, we don't always have as much say. They're in the cath lab, we'll get a call, and typically the phone call would be that we're going to stent your patient. They're going to give me that FFR information, which was correctly done. They're going to tell me a proximal LAD lesion, and they're going to be like, are you okay with stenting it? And I think typically that's what I will see, even if I have other opinions where I think that there is a role for other testing, that it doesn't always stop there, and that also medical therapy can be an optional. This is a higher risk lesion, at least based on probably what would come to me as a phone call, where I don't get to necessarily see what they're seeing.
Thank you very much. Let me go now to an interventional cardiologist. Javier, you see this stenosis. What would be your reflex at the first glance?
Well, thank you, Emanuele. It's very interesting. First of all, this patient did not have ischemia test as such. He had a CT angiogram, and actually the coronary angiogram was complemented by a functional intracoronary functional test, FFR, which indicated that this was a flow limiting stenosis. So if everything was done properly, if this measurement is accurate, you will be in a situation that is endorsed by the clinical practice guidelines, saying that you have identified flow limiting stenosis and that this may account for the symptoms of the patient.
Thank you very much.
You will be moving to treat it.
Sorry to have interrupted you, and thank you very much for your feedback. In the meantime, I've got the feedback of the poll. So I can tell you 35% of our colleagues would just go on, close the story, and stent the proximal LED. As you were saying, Javier, after all, we are following the clinical practice guideline. We did in geography, we confirmed the functional significance. What are we waiting for? But still, what's interesting to me is that 54% of our colleagues would still do imaging first in this patient. No one would send this patient to the surgeon, and the remainder would agree with Marta by sending this patient, well, by giving it a try to optimal medical therapy first. So 11%, just for your information, Marta. Okay, so now let's move on to the next slide, and let me share with you what actually happened in this patient. So, well, I must admit, and I think Javier, giving his experience with intracoronary physiology, already smelled that was something wrong here, and rightly so, because we forgot, I must candidly admit that, we forgot to administer intracoronary nitroglycerin before assessing fractional flow reserve in this patient. Therefore, we first gave an IC bolus of nitrates, and then we repeated again the angiogram, and interestingly enough, there was a significant focal vasospasm of the proximal LED. Now you can see, as a matter of fact, how this proximal LED lesion looks like, more of an intermediate stenosis severity, much more in agreement with the CCTA as it was in the beginning. Now, we measured the fractional flow reserve in the second setting, which is the proper setting, namely with epicardial and microvascular dilatation, and we obtained a value of FFR that is much higher than the one obtained before, 0.78. What is also interesting in this pressure tracing is that we also performed the hyperemic pullback that showed only a limited pressure drop at the level of the stenosis, while the remainder of the hyperemic gradient was attributable to a diffuse disease. So in this case, an improper fractional flow reserve assessment, let me just move on, an improper fractional flow reserve assessment might have resulted into a stenting of the proximal LAD stenosis. Yet, after understanding that the focal stenosis was only part of the problem, which was most likely caused by vasospasm and diffuse disease, we decided, much like Marta was proposing in the beginning, and together with 11% of our colleagues, to optimize the medical therapy first in this patient. So to come back to the focus of our session, the take from this message is, if you see a coronary stenosis, does not necessarily mean that you should stent it, because the patient might be better off with optimal medical therapy, because the cause of symptoms might be elsewhere and not necessarily be improved by implanting a stent. After all, coronary artery disease is multifaceted, and by focusing only on the severity of the coronary obstruction, we might miss the opportunity to better understand the true origin of the patient's symptoms. And on this, I'd like to hear Marta's opinion. Marta, can you take over?
Yes, thank you. So I totally agree with you. You know, there's this overt focus on obstructive coronary disease because that's what we can see. It's just the tip of the iceberg, right? But there's so much more that can be going on that can cause ischemia. And, you know, we really need to move past that. The obviously, even non-obstructive coronary disease, we see it often, and we used to think it was benign, and that when you didn't have a 70% or greater lesion, that somehow it didn't matter. But we also know it's even further than that. The microvascular system can cause ischemia, and it can also be the patients that we're seeing where they don't even get relief, even if you find an obstructive or non-obstructive lesion, but they actually have signs and symptoms of ischemia. And this is true for INOCA and MINOCA. If you think of it in this way, look below the iceberg. Always, us Canadians will bring the iceberg to the story, even if they're melting. So, we have this unifying terminology. And again, I'm going to be talking about MINOCA because I'm going to be talking about the acute coronary syndrome group. And as you all know, we know if we have a STEMI or an unstable angina or non-STEMI, we're very familiar with that. But now we really need to be also including MINOCA as one of the potential diagnoses that you're going to end up with. And of course, for stable coronary artery syndrome, again, there will be people with obstructive disease. There will be people with INOCA, and there can be actually a combination of the two, just as we were saying. You don't have to, they aren't exclusive necessarily. It's just a question of what's contributing to the patient's symptoms the most. And for MINOCA specifically, there's the cardiac causes, the ischemic causes, and then there's the non-ischemic causes. And sometimes they're very obvious, the non-ischemic causes, by other things. When you do an LV gram, for example, or if you have already have done an echocardiogram, either in the emergency room or at the bedside, you might already know that they have a stress cardiomyopathy even before you take them to the cath lab. But in the cath lab, especially in the setting of normal coronary arteries or no obstructive coronary arteries, you may do an LV gram and go, okay, that looks like Takotsubo's, or that looks like a stress cardiomyopathy. We know what's going on here. Myocarditis, again, we can be fooled. And so we need to definitely assess for that, and other cardiomyopathies as well that may appear, again, by our imaging. But when it's ischemic in nature, it can be many different things. So it's not just one diagnosis is the point I'm trying to get at. When you say the words MINOCA, you haven't made the diagnosis quite yet. You're getting there, but you need to work a little bit further down the line to find out what's really going on. So coronary microvascular dysfunction, is that what's going on? That might be one of the potential ischemic causes. Plaque rupture, we have a lot of data where we'll see plaque rupture in the microcirculation, and that could be one of the causes. Plaque erosion as well. In situ thrombosis can be also a diagnosis, and spontaneous coronary artery dissection. Again, usually in the cath lab, you'll recognize that, let's hope, and be able to immediately know what's going on. And again, much more common in women, but not unheard of in men. And vasospasm, like the case that we heard, again, can be seen. So those are the ischemic causes that you're looking for. And we're really lucky now. We've really moved away from this overt focus on obstructive coronary disease. The ESC guidelines were really the first to actually talk about, when you have MINOCA, what are the next steps? What are the invasive tests, whether you're in the cath lab or whether you're doing imaging after? How do you do provocative testing, how you use OCT or IVUS, and what laboratory studies you might consider doing as well. But then making a diagnosis was the key part of these guidelines that came out, whether that's with the invasive investigations or with cardiac imaging. And so, again, some of you may say, well, I don't do these things at my institution. It may not be that you have to do them, but you need to get them to a place that will make the diagnosis. It doesn't just stop once you don't see an obstructive lesion. And I think that's the most important thing. Now, the American Heart Association also, after the ESC guidelines came out in 2017, we have a statement on MINOCA, and they are very compatible. They're very much like the ESC guidelines in terms of first coming up with a working diagnosis. What is MINOCA? Again, the idea that it's not just a single diagnosis and that we need to do other testing. And, again, imaging is part of it, and in the cath lab is a big part of it if you're fortunate enough to have that. I will be honest, in the United States, I will say that it's very challenging to be able to get in the cath lab for people to do some of the invasive testing that we're talking about here, whether that's OCT, whether that's doing coronary functional assessment. That's the bigger challenge, I think, rather than imaging imaging. And so we end up seeing these patients after their events and sometimes making decisions, maybe even when you might not see something on imaging because the time has passed too long, where you don't see evidence of ischemia anymore or infarct anymore. So you don't always know when you're going to get to see these patients. But SCAD, I think we're getting better at recognizing in the cath lab, and that one is one that will get a diagnosis right away. So the diagnostic criteria for MINOCA is really here. You know, universal acute myocardial infarction criteria you use as, and then with non-obstructive coronary arteries can be part of it, meaning that they don't have an obstruction that's above 50%, and then with no clinically overt specific cause for the acute presentation, meaning that if you know that they have Takotsubo's, or if you know that they have myocarditis, or you suspect it and you do the imaging for it, you're not going to label those patients as MINOCA. You're going to label them as the diagnosis that you make. For the rest, you need to start working them up for the other potential causes. So let me just share with you a case, and this is we see these cases all the time, and so this is just one MINOCA case that I pulled. This is a 55-year-old female. She has hypertension, a family history of premature coronary disease, and she presents to the emergency room with central chest pressure. And she's diagnosed with an anterior myocardial infarction by the EKG, which you can see down below, with ST elevation, and she has elevated troponin. So of course we activated the cath lab at the bedside. They did a point of care ultrasound and the ejection fraction looked normal. And then she goes for the cath, and the cath shows no obstructive coronary arteries. They do a LV gram, and again, the LV gram doesn't show us anything that we didn't see on the echo. It looked really normal. So now we're here. We're here where we're talking about MINOCA. This is our working diagnosis, but it doesn't tell us necessarily the next step.
That is a very nice and comprehensive recap of the mechanism and current guideline recommendation, Marta, for what MINOCA concerns. And thank you very much also for this nice case example. Now, before asking what our colleagues will do from home in managing this patient, let me just inform you that we have a very active group of colleagues. We have got lots of good comments and questions. I just want to reassure, and I noted down their names, Bogdan, Marcio, Lian, Mohammed, that your points will all be addressed. Now, allow me just to fit your question within the flow of the discussion, but I will come back on all the interesting points you raised. Okay, let's now focus for a minute just on this specific case that Marta has shared with us. Now we are dealing with an acute patient, diagnosis, ST elevation myocardial infarction, working diagnosis, MINOCA. And here it comes, the second poll and the additional questions to you. Now you have this approach, you have these patients on your cath lab, you have these patients in your ward. What is the approach that you would use? So the angiogram didn't show any coronary stenosis. So this means that the job is done and you would conclude only with coronary angiogram. If so, choose option number 1. If you would do some invasive provocative spasm testing, choose option number 2. If you would do some intracoronary guide wire physiology assessment with Doppler pressure wire, choose option number 3. If you would do imaging, choose option number 4, Ivor CT. And if you would perform a combination of all those, choose option number 5. And I have to apologize at this stage with Marta, as it is a very much interventional cardiology oriented poll. You won't see any non-invasive imaging there, but there we really value your contribution, to really pull these interventional cardiologists on the ground and inform us on what are the additional options. But I'll come back immediately to you on this. Let me first ask the opinion of the interventional cardiologist. Javier, while our colleagues from home are reflecting on this poll, what would be your approach in this patient?
This is a very interesting case. And of course, I think that Marta already paved the way to tell us that the patient was not having a Takotsubo syndrome, because she says that that the left ventricle looks normal, because otherwise, typically, we will expect to have a Takotsubo syndrome, which in a way is also something that deserves some research. Now, I must start by saying that we performed a lot of cases with acetylcholine testing and intracoronary measurement of coronary flow reserve and resistance. And I think that obviously in this case, this will be one of the options. But once said that, I have to be honest, and I must say that whenever we have a patient, if this is an acute situation where the STA changes have happened only 1 hour before something, we probably will not proceed immediately to intracoronary acetylcholine, but we will be probably more focused in trying to understand if we see any clues from the perspective of the substrate. I think that OCT probably will be the test that we will be performing, with a very low threshold, as soon as we will see that there was something abnormal somewhere, and you might identify, from an erosion or some remnant thrombus indicating that there was some sort of a thrombotic event, or sometimes even a hematoma in the coronary arteries of this lady. And then subsequently, after that, if that shows nothing, then I think that probably we will go to some additional tests. I'm sure that Marta is going to illustrate us now on the current evidence of how non-invasive testing may also guide us. Subsequently, we may come back and perform intracoronary testing with acetylcholine and adenosine.
Yeah,
Thank you very much. Sorry.
Oh, sorry. I was just going to say, I agree with you, especially the very good point about in an acute MI setting using acetylcholine, that tends to be not what we do either. And I think that if we're lucky and in the cath lab, they'll do OCT. It can tell us a lot of information right then and there, especially with the other information. They've done an LV gram. They don't see the Takotsubo. So then we don't have an answer. We don't see abnormal left ventricular function. We don't have another reason right now for it. I'll just be honest, and I said this from the beginning, I'm a non-invasive cardiologist, and I tend to see these patients later after their event, because people are like, okay, they have no obstructive coronaries, they go to this particular clinic, and then we see them later. And so later means that right then I don't have the cath lab, right? So if you're lucky to have the cath lab on board, ready to do that, at the time, you can get some answers. But otherwise, cardiac imaging, I think, is what we'll use in the outpatient setting when we follow up with these patients, trying to make a diagnosis. Now, some might argue that that's a little too late. Their acute event is over. You may not see evidence anymore of myocardial damage at that time. It depends, obviously, on the time, but you may be able to get evidence of ischemia. But we do use cardiac MR a lot and PET scanning a lot. And if you have the option to do a stress, maybe again, these are people that we'll see later on. So we don't fear doing a stress test, because usually at best it's a week later. To be honest, more often it's a couple weeks later when they actually get into our clinics.
Thank you very much for these valuable feedbacks. Let me just inform you on the preference of our colleagues. I can tell you that only 5%, of course, we are speaking of a very well-educated group of colleagues here who are following perhaps the whole series of the INOCA webinars from the beginning. Only 5% would be happy with coronary angiograms alone. 14%, so 15% would choose for invasive provocative spasm testing. 16% would choose for intracoronary pressure measurements. Again, 16% IVO0 CT, and the majority, 60%, would have a combination of these tests. So it's interesting. It really means that the majority of this group would be interested in understanding really the mechanism behind these acute coronary syndromes. So Marta, why don't you guide us through this case, what you did next?
Sure. So again, just to remind you, you know, that MINOCA is a working diagnosis and it's really a syndrome. You haven't really made the diagnosis till you have more information. And that's really, you know, again, we're looking for plaque disruption, we're looking for vasospasm, we're looking for dissection or thromboembolism or microvascular dysfunction, or to make a diagnosis of supply demand mismatch. But that's why I don't think anyone was wrong when you said everyone chose the last choice, because depending on what your clinical suspicion is, you may need a combination of those other studies. Now, I told you that when I see these patients, of course, it's a little bit later usually for me. So for this patient, they got a cardiac MR, a stress MR, and you can see that we saw evidence of anterior subendocardial ischemia, or actually evidence of a myocardial infarct is how it was read to us at that time. So they didn't even do the stress part. They saw these images and they're like, okay, well, you have what went on there. So that's very helpful. Again, because we tend to see them in a delayed fashion, it is different if you don't, if you get it right away in the cath lab. But this is what we saw in this case. Now, not to say that the other testing choices would be wrong. Everybody will have different options at their institution. So just to remind you again that these guidelines are excellent from the ESC. We use them all the time to guide our treatment. And you can't, like I said, when they present as an ST elevation myocardial infarction, obviously they urgently go to angiography, but it's the question of when you find no obstructive disease, nothing over 50%, what do you do with them? How do you don't stop there, that we need other assessments to help us make a diagnosis and hopefully treatment plan. So in those guidelines, you'll see that, we have many options of how to use invasive testing to enhance our diagnosis and come up with a diagnosis, but also cardiac imaging has an incredible role. And again, every one of us sees these patients at different points, depending. I know this is a more interventional group, so IVUS and coronary functional testing is definitely something that can help us. But if you see them later, especially when they have ongoing symptoms of angina, and if they did receive a stent already and they continue to have symptoms, the same symptoms that brought them in, you may end up using more of your non-invasive imaging testing to help drill down. Maybe they had an obstructive lesion, but it could be that the microvascular system is actually what's causing their symptom. Of course, if you have other diagnoses like pulmonary embolism and other type 2 MI, that's going to lead us down differently. And hopefully in the specific clinical scenario, you'll be able to make that diagnosis. When you do non-invasive testing, though, things like cardiac MR can help us make the diagnosis of myocarditis, as can echo. So again, use your tools. Your clinical suspicion will guide you what you need to do next. So just to remind you, last year we had the HARP study presented in November of 2020, and this was looking at MINOCA patients. It actually was all women enrolled in this study. And what they did was, the goal was to figure out how can we best make the diagnosis. After you have the word MINOCA, what is it then? So they very nicely showed that when you used OCT and cardiac MR, 85% of the patients ultimately were provided with a diagnosis. Now, there was 15%, obviously, that were without a diagnosis. And we found there specifically that OCT, optical coherence, was really helpful, because 64% of them, you were able to make the diagnosis. And if it was also made on cardiac MR, because the patients often got both, they were very correlated, that the same diagnosis came from both of them. Now, 21% of them got an alternative diagnosis from CMR, usually the non-ischemic causes. And the most common one was myocarditis. And just to remind you, that isn't unusual, because MINOCA is very heterogeneous. And really the number one diagnosis for those patients who are ultimately diagnosed with MINOCA actually is about 33% of them will actually have myocarditis. So again, our history taking matters there as well. But really about the same amount you'll see for acute myocardial infarction and Takotsubo's. And so the acute myocardial infarction group in MINOCA tends to be the coronary microvascular dysfunction group, but there is other diagnoses, and just knowing these frequencies is very helpful for our suspicion and then our eventual workup. Now, just to remind you that MINOCA in and of itself is not benign. Certainly the all-cause mortality is not as bad as somebody who has an obstructive lesion, but it is still not normal. So somebody with an obstructive lesion has about 2 times the greater risk of dying in 12 months compared to somebody who has MINOCA. But that is still 3.5% per year is something that we need to take seriously. Now, one of the reasons that their all-cause mortality is high, I think, is because we really don't know how to treat them. And like I'm hopefully pointing out to you, we're using it as a bucket list, to be honest. It's not one diagnosis. And when we look at data like this is a really elegant study from the Sweetheart study. It's an observational cohort, though, and they looked at all patients with a diagnosis of MINOCA. And those people who got treated with statins and ACE inhibitors did better. There was no difference in use of beta blockers or dual antiplatelet agents. But that doesn't mean that we found the magic treatment is statins and ACE inhibitors. We don't know the treatment, right? Because MINOCA can be one of many different things. And that ultimately, until we know what it is, we can't even start doing the trials of what medication is optimal. And so I think we, again, moving away from MINOCA being the end diagnosis, but actually the initial diagnosis to our workup is the way we should proceed.
There we go. I was on mute. Thank you very much, Marta. I think at this point, it would be important to clarify the optimal adoption of invasive diagnostic tool. This was meant to be a poll to our colleagues, Javier, and I really now rely on you. But actually, the discussion in the chat box has already gone way beyond what was the intended flow of the session. And I think it's high time for us to address some of the comments of the colleagues. So, and what fit perfectly on this test here is the optimal adoption of the invasive diagnostic tool. And there was one question that comes back and again, which is the role of intracoronary nitroglycerin before performing not just a proper functional assessment. I showed this improper fashion of doing FFR, but I honestly, I'm a true believer that nitroglycerin should be even given to obtain a proper coronary angiogram. So I just want to highlight that was a mistaken, that was actually wrongly done, that FFR assessment, just to reassure our colleagues and friends from home that were blaming on me that I didn't do nitrates. But I want to hear Javier on this specific point.
Thank you, Manuel. Well, I think it's extremely important. I mean, you in order to rely in any of these tests, you really have to understand, the optimal circumstances to do it. I mean, to me, it's always very puzzling to see that many colleagues, perform FFR, but they do not ask the patient if the patient had a coffee over the last 12 hours, for example. And, and sometimes you can see rivers of ink talking about the discrepancy between a hyperemic and a non-hyperemic index like FFR or IFR. And actually, there is no control whatsoever in any of these patients had coffee, which of course will account for being an antagonist of adenosine, will be one of the most clear examples of a test that is not properly performed. So I think that performing the test properly is of paramount importance. I think that if we go back to the case of Marta, once that, imagine that this patient was already studied in the acute setting with OCT, you have ruled out that there was, any hint, any hallmark of thrombosis or plaque ulceration or whatever. And then, but perhaps you have additional information on MRI, as Marta has been saying before. I think my impression is that these patients, I will be very keen over the following days to perform a test of vasoreactivity, because the appearance and disappearance, sudden appearance and disappearance of acute ischemia in that way is very typical in the absence, of course, of any other obstructive cause, very suggestive that there is something that is not a structural modification of the microcirculation. So I will put my bet, in this particular aspect. And of course, I will check also coronary flow reserve and microcirculatory resistance in addition to the measurement, the assessment of vasoreactivity with acetylcholine testing.
I just, in the meantime, obtained the result of the poll here. I can inform you that the wide majority of our colleagues would prefer to do intracoronary physiology, so measuring flow reserve, microvascular dysfunction with IMR and so forth. And there is a equal preference for intravascular imaging and invasive provocative spasm testing in MINOCA. That is the preferences and the options of our colleagues from home. I think now we are nicely ready, and we paved the way to the next part of our webinar, because we would now move from the acute setting to the chronic setting. So we move from MINOCA to INOCA, and I would like to hand over the word to Javier, who will introduce us with this second part of the webinar.
Yeah, thank you. And as the title of this webinar speaks about specific scenarios, I think that we should be highlighting that we will now discuss a bit the presence of INOCA in patients who have coronary stenosis. Probably over the last webinars, we have insisted a lot in this situation where you have apparently angiographically normal coronary arteries and still you have ischemia and so on. But perhaps we have not placed enough emphasis on the fact that you also may have a problem in the coronary microcirculation in patients who have epicardial stenosis. And actually, if you look to the clinical practice guidelines, the current definition of non-obstructive coronary artery disease in the latest guidelines on the diagnosis and management of chronic coronary syndromes of the ESC say that if you have a patient who have evidence of ischemia and non-ischemic FFR or IFR in interrogated stenosis in that particular vessel, you have to suspect that actually this is a non-obstructive cause of ischemia. So this is important to keep in mind. Remember that there is a strong crosstalk, and this is something that we will be covering now, between the presence of epicardial disease and microcirculatory dysfunction, both structural and also vasomotor dysfunction. The fact that even the presence of stenosis in the epicardial vessels, I'll try to illustrate that, may exacerbate or trigger the development of subtended microcirculatory dysfunction. And something that is of extreme importance is that if the predominant cause of ischemia in a patient who has stenosis is a non-obstructive cause, the treatment of that stenosis is quite likely to be followed by no relief in the symptoms. That means persistent angina after PCI, that, as you know, has an incidence of about 20%, 25% in the first year of follow-up. So 25% of the patients that are treated with the stents actually do continue having angina. Now, in the next slide, I'm going to show you a very classic experiment that had a look to the reactivity of the subtended coronary microcirculation in a vessel who had no stenosis or that had an epicardial stenosis. This is a study by Baumgart, where the investigators, what they did is they performed an infusion of an alpha agonist, methoxamine, and measured coronary flow. And you can see that in a patient who had no epicardial stenosis, there were no variations in coronary flow with increasing doses of this alpha agonist. But on the contrary, when you look to the patients who had epicardial stenosis, you see that the infusion of this alpha agonist trigger a reduction in coronary flow that, of course, may be causing ischemia. So it's a good example that there is a very strong interplay between epicardial and microcirculatory dysfunction in terms of vasomotor phenomena. But you also may have the other endotype of INOCA in patients who have epicardial stenosis, you also may have structural remodeling of the microcirculation. And these pictures are coming from an experimental model of swine where an epicardial stenosis was generated, and you can see how over time in this particular model you have increase in a remodeling of the arterioles subtended to that particular stenosis, and actually how this thickening of arterioles mimics very much what we see in many patients who have INOCA. Actually, the reactivity of the smooth muscle cells of these arterioles was also abnormal, very much as this has been demonstrated in patients with INOCA. Now, we were saying before that there is a very strong interplay between cardiovascular risk factors, epicardial atherosclerosis, and microcirculatory dysfunction. We know that some of the risk factors for INOCA are the same risk factors, cardiovascular risk factors for atherogenesis. And actually, this is demonstrated very nicely in this study, where you can see the structural changes in the microcirculation in patients who are not hypertensive and patients who have hypertension, and more importantly, how these changes, this structural remodeling, becomes exacerbated in hypertensive patients whenever they have also epicardial coronary artery disease. So, in other words, there is a summative effect of the epicardial atherosclerosis and subtended changes in the microcirculation probably induced for the cardiovascular risk factors. Now, how to measure and how to understand what happens in the patient who has coronary stenosis? Again, we have to remember you that because the main function of the epicardial vessels is conductance, the test that we use to measure if you have a flow-limiting stenosis in the epicardial coronary arteries are indexes of conductance, like coronary flow reserve or IFR. But you also may use acetylcholine testing in case that you think that there may be a dynamic stenosis caused by epicardial spasm. And when you move to a microcirculation, because the main role is matching blood supply to myocardial oxygen demands, this dynamic function of the microcirculation, you have coronary flow reserve, which is an index that explores this dynamicity, and you have resistance, which looks to the changes in conductance caused by the structural changes that we saw before. On the top of that, you may also have vasomotor disorders like arteriolar spasm or microvascular spasm causing ischemia that have to be explored with acetylcholine testing. So, Emanuele, I think that it would be nice to share with the colleagues these patients and to see what they think and what will be the next step. This is a 50-year-old male patient with, as you can see, hypertension, dyslipidemia, type 2 diabetic mellitus, a history of coronary disease. He came from the Indian subcontinent. And the patient presented with a fourth angina, had a positive exercise test in terms of symptoms. There were no EKG changes. We brought the patient to the cath lab. We saw that there were these stenosis in the LAD, performed an FFR, and we found that the values of the FFR were non-ischemic. So I handed it over to you, and we perhaps can get a feedback from the colleagues on how they will manage this patient.
Thank you very much, Javier. That's an interesting case. By the way, I can already anticipate that many colleagues in many practices would have not even measured FFR in this vessel. So this is a patient, young, with many risk factors, with typical angina, a fourth angina. Nevertheless, the coronary angiogram, the exercise ECG is clinically positive, and the angiogram shows 2 stenosis in the mid-LAD. So I can imagine that some colleagues would have not bothered even to measure FFR. In this case, would have just tented it. That is just to challenge a bit your measurement there. But let me pose the question to our colleagues with this poll. What would be your routine strategy in this patient? So Javier has shown that there are a couple of intermediate stenosis there. FFR, nevertheless, has shown an FFR value, a value above 0.8, so non-ischemic. The procedure is done according to you. Secondly, you think you need additional information because there might be something more than physiology, and therefore you want imaging. And as a third option, you want to assess spasm in this patient. So while they reflect a bit on this case, what do you think, Marta? Any thought on this?
Yeah, it's a great case. I think, again, the patient in and of itself had multiple risk factors, and it's hard, obviously, to see that angiogram and see that FFR and say, okay, well, what do we do? It would be very hard for most of us to just stop there. And so I think that having the FFR is certainly helpful and telling us that there's not an obstructive lesion, but what do I do with this patient? So at that point, I would be asking my interventionalist to do some other testing, specifically doing coronary flow reserve with acetylcholine testing, I think would be the right step to tell us if there's something going on, because his story is good, his symptoms are good, got all the way to the cath lab already because of the multiple risk factors and his story. I don't know how we treat him without more information.
Thank you very much. I can inform you on the poll, wide majority, 70% or more, they want to assess microcirculation and possible spasm. 12% to 50% want to address with intravascular imaging. 15% of the colleagues think that the procedure is none. And there is a very interesting comment, actually, that we might want to address from now, that was already posed during the case of Marta, but can perfectly adapt also to your case. Even if in one case we were talking about our acute coronary syndromes, now we are talking about chronic coronary syndrome. The point is, we do all these tests. We do spasm provocation, we do microvascular circulation assessment. But at the end, what can change? That was the question of our colleague. Javier, what does it change practically for the management of this patient? Of course, this is a question very much oriented to interventional treatment, but taking the broader picture, what can change by doing these adjunctive tests?
I think it's a great question, because it is formulated in a landscape of therapeutic nihilism. I mean, a main reason because many colleagues believe that it's not worth investigating is because they believe that there is nothing you can do. Of course, there are treatments. The treatments have been there for a long time. We have effective treatments. But what you need is to give the proper treatment when you have identified the proper mechanism of dysfunction. And I think that this was one of the messages of the MINOCA trial that demonstrated that you can improve significantly the quality of life of these patients. And probably in the future, other studies will demonstrate that perhaps we can improve prognosis. This is something that will come. But we are now at a stage where we have recommendations in the clinical practice guidelines that you have the tools to guide this. And I think that the fact that, I like very much when Martha was saying that she will ask this to an interventional cardiologist. I think that things will start changing gradually when the clinical cardiologist will be asking the interventionalist, can you, at the time of performing the coronary angiogram to this patient, perhaps perform intracoronary testing, because I believe that this patient may have, a problem of non-obstructive ischemia, etc. And the information that the interventional cardiologist will be extremely important for the clinical cardiologist in the follow-up. That's my impression.
Actually, this is a very thoughtful comment, Javier. And that's actually a call to our colleagues and friends, non-clinicians. The interventional cardiologists need to understand the importance of additional information. And most importantly, they need to run away with the idea that if they do these additional measurements, then these additional measurements will translate into a management strategy, into a therapeutic approach. Javier, in the interest of time, let's move on and let's hear how did you manage this patient?
Yes, so basically what we did is we first explored, we knew already that FFR was normal. You can see here why we knew this, because we performed FFR at the same time that we performed thermodilution with intravenous adenosine. Now, you can see that the dynamicity of this microcirculation is severely impaired. It's 1.7, the coronary flow reserve. Typically, you should be with thermodilution more than 2. For this young individual, even higher. I mean, you would expect, that probably, will be quite, in a normal individual of that age, probably will have a coronary flow reserve of more than 3. The microcirculatory resistance is 28. So it is not only that the dynamicity of the microcirculation is impaired, it is that the conductance of the microcirculation, probably because there is thickening or narrowing of the arterioles, it is reduced, or perhaps there is loss of capillaries. More interesting, or complementing to this, was the results of acetylcholine testing. There was no epicardial spasm with acetylcholine, but you can see that immediately acetylcholine testing triggered a spasm in the microcirculation. You can see the ischemic changes, and the patient developed exactly the same chest pain that he had reported before. So in summary, this patient had a very is at the very tail of the spectrum of ischemic heart disease. He has atherosclerosis in the epicardial vessels, which of course imply a worse prognosis because are the seat of acute coronary syndromes. He has non-obstructive ischemia generated because there are structural changes in the microcirculation and also abnormal reactivity of this microcirculation. Most likely when this patient is exercising, the arterioles constrict instead of vasodilating, so it's putting the patient even at a more ischemic level. So what we did, we first, of course, stopped beta blockers because we think that in this particular patient, what predominates is a vasomotor disorder. We started a calcium channel blocker, diltiazem. We make sure that the patient was on a statin. We gave an ACE inhibitor, which has a very salutary effect on the endothelial function. Of course, emphasize the importance of keeping antidiabetic treatment. And on the top of that, we added, of course, aspirin, because this patient has epicardial atherosclerosis. And we discussed with the patient and with the physician the importance of diet and lifestyle recommendation. My final slide has to do with the consequence of what happens if you ignore these type of things. So in this slide, what you are seeing is a beautifully performed two-stent technique in the LAD and the diagonal. So the interventional cardiologist made a great job. You can see that there's no restenosis whatsoever. The problem is that this brought no relief of angina whatsoever to the patient. So we brought the patient back to the cath lab, because she continued having symptoms. We performed acetylcholine testing. Here you can see that with the low dose was normal, but look to this non-reflow phenomenon when we gave 100 micrograms of acetylcholine testing, indicating, of course, with EKG changes and the same chest pain that the patient has, indicating that this patient has microvascular spasm. And she also had some dysfunction. We're not going to go into that at the level of coronary flow reserve. But it's just to illustrate that, you really, as an interventional cardiologist, you must master performing a decay crash and managing bifurcation so beautifully as it was done in this case. But you also have to be able to identify patients where the cause of this chest pain of ischemia is not actually the stenosis, but it is lying beyond. That is for the sake of our patients.
Javier, I have to thank you because this case is really an eye-opener because this is exactly the situation where we would invest a lot of time, energy, and resources in treating, in offering what we think it is the best treatment for our patient. But then the patient comes back and again to our outpatient clinic complaining always of the same symptoms. And what I also liked from your case is that you said, interventional cardiologists are ready to perform complex situations, complex procedures like this one, while like Marta, who's very skeptical, and she's commenting it's complicated to do all these procedures, FFR, IVUS, OCT, in the same cath lab time on the acute event. That's the reality. So is it really so complicated as Maria is concerned?
Javier. Oh, no, by no means. I think that we had a lot of occasions over this series of webinars to demonstrate that, as an extension of your diagnostic cardiac catheterization, this probably takes you 15, 20 minutes, which is peanuts, considering, the impact this has on the clinical management of the patients. These patients typically, are in a loop of never-ending tests, consuming healthcare resources, And of course, with the uncertainty of what is the diagnosis, which causes a lot of anxiety.
We have a massive list of questions, I must say, and I'm very happy of this. If you'll help me in answering very quickly, we'll try to address many of them. One more for you, Javier, and then we go to Marta. In your case, the colleagues saw that there was a guide wire during the acetylcholine test. Is it your clinical practice? Do you always leave the guide wire in place?
Yes, we like to do it. I mean, particularly if we are using Doppler, we like to have it there because it gives us additional information on the responses in terms of flow to the increasing doses of acetylcholine. So we like to do it like that. And typically, you know, whenever we do an acetylcholine testing, it's quite likely that we are also going to measure the response to adenosine in terms of coronary flow reserve, IMR or HMR.
Now to Marta, quick question and answer, Marta. Do you usually give aspirin in patients just with arteriosclerosis? I mean, patients without obstructive lesions. Would you give aspirin?
Ischemia, so definitely I use aspirin and the guideline recommended therapy, and that's why, you know, making the diagnosis of coronary microvascular dysfunction is so important, because then you have therapies.
Then another question, I think specifically related to this last patient from Javier showing this vasospasm, again from Marta. How about nebivolol? After all, he has a coronary vasospasm, and nebivolol is the only beta blockers that might help. That is the question from Uman. What do you think?
Marta, you want to take that one?
Sorry, yeah. If you're asking me, I'll say that I think this patient was on a beta blocker, so I think it was a good choice to switch them to a calcium channel blocker. I think sometimes, though, you have to try different things in these patients because of their symptoms. You know, it's really at this point about their symptoms. They come back again and again and again, and sometimes it's trial and error figuring out which medications will work for them.
Okay, now we jump from INOCA to MINOCA. I apologize for this continuous change in scenario, but that's the way the things are coming here. There was one colleague that saw in your algorithm that you mentioned D-dimer means pulmonary embolism. I guess it refers to one of your previous slides. But he says, you know, D-dimer is not infrequently altered in atherosclerotic acute coronary syndromes. So what is your management? What is your approach there?
Yeah, I mean, of course, as we all know, pulmonary embolism is a clinical diagnosis. And so you may end up getting blood work because they have symptoms that you're not sure, is this ischemic? Is this even their heart? If you're going down that route, that is the reason that's part of the guidelines, that if you're suspicious of a pulmonary embolism and you're getting the D-dimer because of that, you know, you're probably going to do other imaging testing as well. So it's not in isolation, nor was any of that meant to be in isolation. Okay, Javier, there is really Dimitri who's challenging you. It's not peanuts to use all these tests because they have considerable costs. How do you address this?
Well, I think that if you compare the costs of using acetylcholine, which is a very cheap drug, you know, pressure guide wire, which basically, you know, is as expensive as a balloon or whatever. If you compare that with the healthcare costs, that means that this patient is bringing, you know, coming back to the clinics, having additional routine, every certain time we'll have another non-invasive test for ischemia, another cardiac cath, etc., etc. That is really, really small. I don't have evidence to give you evidence on the cost effectiveness of these techniques, but we know that INOCA is a very, very resource generates a lot of loss in healthcare resources.
Now it's time to wrap up. If you agree, I'd like to ask to Marta just to show us the very important takes for MINOCA patients. Marta.
Yeah, just to highlight again, just to wrap it up, I mean, I hope I've convinced you that MINOCA is a syndrome and not really a diagnosis, even though it gets used a lot in that way. We know MINOCA and INOCA, for that matter, is much more commonly seen in women than men, but we should think about it in men as well. And making the diagnosis really requires further investigation, as we've been talking about in this whole webinar. I think we still need some work about guideline-directed medical therapy. There might be unique therapies. I even think SGLT2 inhibitors have potential, especially in the coronary microvascular dysfunction, since we think that HFpEF is on that same potential pathway. And we saw the data come out from Paragon that might be interesting for us to look at in this population. We still have a lot more to figure out about this. But I also think that, it's not a benign prognosis, and it's also not inexpensive to not treat them. As you already heard, it's as costly as having single vessel disease when you talk about non-obstructive. So think about that when you're taking care of these patients with MINOCA.
And now to Javier, your most important takes for INOCA patients.
Well, I think that, it's we are attending a change in paradigm in a way. When I was at medical school, I think that it was something like 35 years ago or something like that. We were told that, that there was something called microcirculatory dysfunction, et cetera. But actually, over my career, I never saw people making the diagnosis of that particular thing. And now the time has arrived, to have the possibility of really understanding how this is affecting the life and the prognosis of our patients. So hopefully all that has been covered in this webinar and the series of webinars on INOCA may trigger interest in our colleagues and contribute to move in this direction.
I cannot agree more with all what's been said by you and by Marta. It reminds me about the usual story of the finger and the moon. I have the impression that many times we keep focusing on the finger and we lose focus from the moon, which is the real problem and the real cause of symptoms of the patient. With this, I'd like to thank very much Marta and Javier for their extremely valuable contribution to this discussion of this very important topic. I'd like to thank the PCR team for their support. I'd like to thank Abbott for the unrestricted grant support. And please do not forget that if you miss anything from this very important PCR webinar series, you can all find them on the PCR Online website. Thank you very much, and wishing you all the best.